And the next syndrome we want to discuss is on the Weger syndrome. Weger is an acronym for Williams tumor, aniridia, genitourinary abnormalities, and mental retardation. Clear? So what is the problem in Weger syndrome? So the problem in Weger syndrome is located in chromosome number 11, where you have a area called Weger region. And if this area is deleted, and this is located in the short arm of chromosome number 11, not in the long arm of chromosome number 11, like in Pratt-Whitney syndrome, it's in the short arm of chromosome number 11. So deletion of this Weger region will result in deletion of certain key and crucial genes. The first gene that is very, very important is PAX6 that is deleted, and deletion of this PAX6 gene is thought to be the reason for development of one of the key component of Weger syndrome called aniridia. Aniridia may be partial or complete, which means there will be a partial or a complete loss of iris. Aniridia is very specific for Weger syndrome because very few conditions produce aniridia, and at the same time, it will result in significant photophobia because iris is the one that controls the amount of light exposure to the eyes. If you don't have the iris, it will result in photophobia, and plus or minus you can develop cataracts over a period of time. And second gene that is deleted that can result in development of some of the key components of Weger syndrome is WT1 deletion. So remember, Williams tumor 1 gene is very, very important for kidney as well as your genital development. So this Williams tumor 1 gene deletion chromosome number 11 in the Weger syndrome is the main reason for development of Williams tumor, that is referred to as nephroblastoma. In some of these children, Williams tumor incidence is approximately 60%. At the same time, this also results in development of genitourinary anomalies that is seen in majority of the individuals, approximately 60 to 70% of the individuals. So genitourinary anomalies that you will be seeing will be different in males and females. In males, you will be seeing cryptorchidism and hypospadias, that is undescended testis and hypospadias. And in females, you will be usually seeing a streak ovary or a gonadal dysgenesis resulting in 46XX type of gonadal dysgenesis, which is going to result in a disorder of sexual differentiation. Finally, these patients will have mental retardation, that is intellectual disability, that is R stands for mental retardation in Weger. So they might be having intellectual disability, and the reason for intellectual disability is completely unrecognized. Which gene is causing this intellectual disability, we don't know. And many of these patients will be having a little low IQ, developmental delay. At the same time, they'll be having attention deficit hyperkinetic disorder and autism spectrum disorders as well. So they'll be having mental retardation, that is intellectual disability. And some of these individuals may be having obesity, and that is due to BDNF deletions, because BDNF Weger pathway is closely related to stimulation of the POMC CART mechanism on the anorexogenic pathway. Suppose if BDNF is deleted, this will result in failure of the anorexogenic pathway to be stimulated, resulting in uncontrolled orexogenic pathway stimulation, resulting in hyperphagia and obesity. It's not seen in all the individuals. Suppose if BDNF deletions are there and your hyperphagia is there, that syndrome is also referred to as a separate syndrome called Weger O, but it's better to avoid this kind of terminology. It's better to stick on to the term called Weger syndrome. And obviously, this gene deletion can be easily identified by FISH using probes that are specific for the Weger sequence. So once you use FISH, you will be able to find out the deletions very easily. So FISH is a very important modality. Identify the deletions, and treatment is only like supportive. So you don't have any specific treatments for the same. For example, if you have aniridia and related photophobia, you can use certain tinted glasses. Apart from that, there is not much you can do about this Weger syndrome patients. And third syndrome that is associated with obesity is Alström syndrome. Alström syndrome is due to problems in a gene called ALMS1 gene, that's an Alström syndrome gene 1, which is present in chromosome number 2, and it is inherited as an autosomal recessive fashion. And patients will be short, patients will be obese, And obesity in Alström syndrome has a 100% incidence, unlike Auger syndrome, which has only 50 to 60% incidence. And this obesity can result in multiple complications like type 2 diabetes mellitus and metabolic syndrome. And obesity is generally due to hyperphagia that is happening in the childhood. And many of these children will be blind because of two reasons. Either it could be due to cone rod dystrophy or frank retinitis pigmentosa. Anything could be the reason for the blindness. And they might be having mild to moderate sensory neural type of hearing loss, and they'll be having multi-systemic involvement. And the most important is going to be the cardiac, one of the very common cause of death in these individuals. Cardiac in the sense, more than 60% of the individuals will have cardiac involvement in the form of dilated cardiomyopathy. This is a non-ischemic DCMP, dilated cardiomyopathy. And usually it manifests within the first few days after birth itself, most of the time. And you can have other organ defects like kidney problems, liver problems, pulmonary issues, urological problems, and urologic malformations. And they tend to develop some kind of scleroderma-like illness, which might mimic it, but it will come at a much younger age and it will not be a typical scleroderma picture, and they'll have a multi-systemic fibrosis over a period of time. That's a very important point. And diagnosis is made using a clinical criteria termed as Marshall criteria. Marshall criteria, the name Marshall criteria has been applied to many other diseases also, but in this Alström syndrome also, the diagnosis is based on a clinical criteria called Marshall criteria, but the confirmatory diagnosis is based on identification of this mutation in the ALMS1 gene in the chromosome number 2. Fine. So this is Alström syndrome. And the next syndrome we are going to discuss will be on the Lorentz-Moon-Bidet syndrome. Obviously, I'm not going to write the spelling of Lorentz-Moon-Bidet syndrome and screw myself on. So let us write as LMBBS. So the problem here will be in the BBS group of genes, which is seen in multiple different chromosomes, and we really don't know the exact reason for Lorentz-Moon-Bidet syndrome. But there are some textbooks which confuse you by giving Lorentz-Moon syndrome is different, Moon-Bidet syndrome is different. But anyway, the international nomenclature has clearly said that they're not different, and only subtle difference the clinical features are there, but that doesn't make any big difference. And apart from that, majority of these individuals will be having serious obesity. Typically late childhood is where they will develop obesity, unlike other conditions which you have seen where they'll be having early obesity, which is the risk factor for diabetes and other obesity related complications. And apart from that, they'll be having renal problems like renal cysts, they'll be having polydactyly, and they might be having visual issues like retinitis pigmentosa. Many of the syndromic problems will be having visual issues, with certain exceptions like Prader-Willi syndrome where you don't have that much of visual issues, but the majority of the other obesity related syndromes will have visual problems. And the next syndrome we are going to discuss is on the Albright's hereditary osteodystrophy, which is usually seen in pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. Not all types of pseudo-hypoparathyroidism you will be seeing Albright's hereditary osteodystrophy. There are some selective types of pseudo-hypoparathyroidism where you will be having Albright's hereditary osteodystrophy, and you pseudo you have only one type. So that is going to have Albright's hereditary osteodystrophy. The difference between pseudo-hypoparathyroidism and pseudo-hypoparathyroidism will be made depending on the genetics, depending on the biochemical features. For example, pseudo-hypoparathyroidism patients will have multiple hormone resistance most of the time, and especially at the receptor level, not only parathyroid hormone resistance, and they'll be having abnormal biochemistry in the form of calcium and phosphate abnormalities and PTH abnormalities. Whereas pseudo-hypoparathyroidism patients will not have any biochemical problems, normal calcium, normal PTH and normal phosphate, but they'll be having skeletal issues like Albright's hereditary osteodystrophy. The details of all these things we are going to discuss in detail in the rheumatology section on bone. So we're not going to touch it right now. So let us go and see what will be the features in this case. These children will be obese and short and plump. That's very characteristic, and they'll be having round face because of the obesity, and they'll be typically having this brachydactyly, and that is a result of underlying brachymetacarpia. Especially this fourth, fifth or fourth metacarpals will be unusually short in these individuals, resulting in small digits. Their fingers will be small and short compared to the other fingers. So that's what we refer to as a brachymetacarpy. And this also leads to an interesting sign called a knuckle dimple sign, and the details of which we'll be seeing in the rheumatology section as I promised. So this is Albright's hereditary osteodystrophy. And you have another syndrome called as Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome is due to problem in the chromosome 11p15.5 region. This is where the Beckwith-Wiedemann syndrome problem is located. And like how Prader-Willi syndrome, the problem is in the chromosome number 15q, 11 to 13. Similarly, in Beckwith-Wiedemann, it is in chromosome number 11p15.5. That's where the problem is. And involvement of this area in Beckwith-Wiedemann syndrome will result in excessive production of a growth factor called insulin-like growth factor 2. And that is the reason for the overgrowth that is seen in these individuals. And at the same time, they will be producing reduced levels of cyclin-dependent kinase N1C, that's called CDK-N1C, which is actually a cell checkpoint inhibitor, that's a tumor suppressor gene. This will result in development of multiple tumors. So what are the overgrowth features in these guys? So they'll be having neonatal macrosomia, and they'll be having macroglossia, which is a very classic sign, very big tongue, and they'll be having hemihypertrophy as well. Tumors that they tend to develop include Wilms tumor, that is a nephroblastoma. Then they can develop hepatoblastoma, and they can also develop pancreatoblastoma. Apart from that, they have some other features per se, like they will have a mid-facial hypoplasia. They can have abdominal wall defects in the form of omphalocele, and they will be having hyperinsulinemic hypoglycemia because of high insulin production, because of again excessive IGF-2. That is the reason, because it's an insulin-like growth factor. So because of high levels of IGF-2, they act like insulin, and hyperinsulinemic hypoglycemia may be the case in these individuals. So what are things that you have to remember here? So usually in exam, you'll be getting this macroglossic child, where the child will have a big tongue. Along with that, they will be coming with an omphalocele, a big abdomen with some form of herniation in the umbilical region. You can clearly tell that this patient is suffering from a Beckwith-Wiedemann syndrome. So this is how you identify in exam. So these are the key classic pointers in exam that tells you the child is suffering from a Beckwith-Wiedemann syndrome. And apart from that, you have multiple other syndromes like Fragile X syndrome. So some of the features of Fragile X syndrome, easy. The children are going to have mental retardation for sure. That is intellectual disability. Along with that, they will have macroorchidism. This is a very classic exam question. So macroorchidism. So if you see the word macroorchidism in exam, usually it goes towards Fragile X syndrome. And they might have a prominent lower jaw. Once again, very classic. And they have a joint hyperflexibility. They'll have hyperflexible joint, and they'll have a large and protruding ears as well. But most important clinching point in exam with regards to Fragile X syndrome is going to be the macroorchidism that you're going to see. Apart from that, you have Carpenter syndrome, which can produce obesity as well. Carpenter syndrome will be associated with polysyndactyly. I'll show you the image in some time. But more importantly, they will be having that craniosynostosis, fusion of sutures. Because of that, the shape of the skull will be abnormal, and they'll be having cardiac issues also. So if they give you an image of a child who's having craniosynostosis and polysyndactyly, think about Carpenter syndrome. And you have other rare syndromes like Rubinstein-Taybi syndrome, which is not important for exams. Just for completion's sake, I'm just mentioning these names. And you have another disease called ROHH-AD, which also can cause obesity, and the underlying genetic problem is unknown, where it is an acronym which stands for rapid onset obesity, and H stands for hypothalamic dysfunction, And another H stands for hypoventilation, which is supposed to be the most common cause of death in these individuals. And AD stands for autonomic dysfunction as well. Fine. So we have completed the syndromic causes of obesity, and let us move on to the image plate. And the first set of images I'm going to discuss is on the ever important Prader-Willi syndrome. And this is a typical example of a child with Prader-Willi syndrome where they're going to be obese with a round face, which you can classically note, and they'll be having this classic almond-shaped eyes with classic thin upper lip and a prominent philtrum and an upturned nose. Very, very classic of a Prader-Willi syndrome. And this is an example of a Prader-Willi family where most of the child in that family tends to be morbidly obese and they'll be exhibiting serious hyperphagia. And this is an example of a Prader-Willi hand where they tend to have small fingers, and that is what we refer to as acromicra, very classic of Prader-Willi syndrome, and they're going to have a straight ulnar border along with the straight leg border. Very classic of Prader-Willi again. And these are very important images for your exam. Fish probes. And for example, let us assume I'm giving a fish probe that is complementary to 15q 11 to 13 region. And these are the two probes that I'm seeing here. That means this red color that I'm seeing, red dot I'm seeing in this metaphase chromosome is the 15q 11 to 13 probe. And I'm seeing two probes, which means it's very, very clear that it's a normal one. So I cannot tell it's a normal one, which means there is no deletion or translocation here. Fish is not showing any abnormality. That's what I'm going to comment on. But whereas here, I'm seeing only one red dot, I'm not seeing the another red dot. So where is the another red dot here? So this is suggestive of a deletional form of a Prader-Willi syndrome, where one of the fish probes for 15q 11 to 13 is actually missing. So definitely it's deleted. So that is the reason why that particular child who are suspecting to have Prader-Willi syndrome can be confirmed to have Prader-Willi syndrome. Suppose if fish studies does not show any deletion or translocation, it does not mean that the patient is not having Prader-Willi syndrome. Still, if you have strong doubt of Prader-Willi syndrome, go for methylation sensitive PCR. So do methylation studies. That is very good. So this is a classic example of a child with Carpenter syndrome, where you're going to have craniosynostosis. You can see abnormal shaped skull, and you'll have strabismus, all right. So because of the shape of the skull, and more importantly, you'll be seeing polysyndactyly. When you see craniosynostosis, polysyndactyly, think about Carpenter syndrome. And why it's polysyndactyly? Because there is polydactyly here, but many of the polydactylic fingers are fused to produce single fingers, so that's why it's a polysyndactyly. And this is a classic child with the Albright's hereditary osteodystrophy, where you can see a short and plump child with a round face, and you characteristically see the brachydactyly, that is typically due to the brachymetacarpia. And you can see the small fingers, especially the fourth and fifth in this case, that is due to brachymetacarpia. The metacarpals are short, and this is clearly evident from the short fourth and fifth metacarpals in this particular patient. And you can also see the basal ganglia calcification, which is usually seen in pseudo-hypoparathyroidism. Very common in pseudo-hypoparathyroidism is basal ganglia calcification. That is actually due to high phosphate-driven calcification in the basal ganglia. And this is an example of aniridia seen in Wager syndrome, where you can see that there is absolutely no iris at all. It's only full of darkish color, and that is due to absent iris. You don't see any iris at all. Aniridia, classic of Wager syndrome. And if you see this kind of image where the child is having macroglossia, protruding tongue like this, with abdominal wall defect showing an omphalocele, this is very typical of a Beckwith-Wiedemann syndrome, as I told you already. And if you see an omphalocele with macroglossia, very classic in exam, very common images in exam, suggestive of a Beckwith-Wiedemann syndrome. With this, we are moving on to the approach to obesity. Remember, in adults, it's quite simple, but in children, you need a proper understanding about this obesity. That's why I'm going to talk about approach to childhood obesity. If you understand this, adults is very simple. Adults only very few causes. Either it could be physiological or it could be secondary pathological, but monogenic and syndromic causes in adults are extremely rare. You'll be getting only drug-related obesity or probably hypothalamic obesity, even which is rare in adults, and probably you're getting endocrinological obesity like Cushing syndrome, which is usually identified by multiple other findings rather than just obesity. Clear? So let us first see how will you approach a childhood obesity. For that matters, first I'm going to look at the growth, puberty, and the development in that particular child. If all are normal, then definitely it is very clear I'm dealing with a physiological obesity. Physiological obesity, and it's not pathological, which contributes to 98 to 99% of the obese children. Once I know it's a physiological obesity, my next step is just to identify complications. Look for complications, whether it is there or not. Important obesity-related complications include non-alcoholic steatohepatitis, so I'm going to look for liver function test, especially the ALT. I'm going to look for lipid profile for dyslipidemias. I'll be doing a OGTT rule out, diabetes mellitus, or I can also start seeing the thyroid profile and all these things because there will be altered thyrostatin in this guy. So just you have to look for complication, that is more than enough. Suppose if these are abnormal, if growth, puberty, development is not normal, and if it is abnormal. So now I have to suspect pathological obesity. So very likely it will be a pathological obesity. So my idea is to find out whether it's a endocrine obesity or a syndromic or a monogenic forms of obesity. So obviously, if I have a delayed growth in puberty, but a normal development, delayed growth in puberty, but a normal developmental milestones, usually this goes towards a endocrine cause of obesity. So some problem in the puberty, short and plump child with delayed puberty, I usually think about a endocrine obesity, but normal developmental milestones. Suppose on the other hand, if the child exhibits hyperphagia, clearly I'm dealing with the genetic forms of obesity. In this condition, I'm dealing with the genetic forms of obesity. It could be a monogenic or a syndromic obesity. So in this setting, I have to see the developmental issues. If the development is normal, mostly it goes towards a monogenic obesity. Monogenic obesity, most of them will have a normal development, even though they might have a delayed puberty and some growth-related issues, but overall the development will tend to be normal. Monogenic forms of obesity, like probably leptin-related issues or pro-convertase 1 deficiency, where they tend to have a normal development. So suppose if the development is abnormal, then clearly I'm dealing with probably a syndromic obesity. So obviously the most important syndrome that you have to look for is the Prader-Willi syndrome, which is much more common in this group. So first I'll be doing fish and methylation studies. If both fish and methylation studies are negative, then only I'll be thinking about other causes. If fish is positive or fish is negative but methylation studies are positive, I'll be thinking about Prader-Willi syndrome in this regards. So if fish and methylation studies both are negative and it is not suggestive of Prader-Willi syndrome, then I'll be looking for the vision abnormalities. If vision tends to be normal, think about Albright's hereditary osteodystrophy. And Albright's hereditary osteodystrophy will have many oscillant biochemical features like pseudo-hypoparathyroidism, or they might be having multiple other features like brachymetacarpia and brachydactyly, so which will tell you clearly that the patient is having a AHO-related obesity. Or if the patient's vision is abnormal, then I'll be thinking about multiple other problems like Alström syndrome, where the confirmation will come either from Marshall criteria or you have to use the genetic testing for ALMS1 gene. So it could be Alström syndrome, or it could be Lawrence Moon-Bidet Bartle syndrome, or it could be a Wager syndrome. So once again, you have to use fish for diagnosing Wager. So if you identify that Wager area deletion, then you can think about Wager syndrome. So this is how I'm going to approach an obesity. Endocrine obesity, if you strongly suspect endocrine obesity, you have to rule out hypothyroidism. Typically, we'll be doing serum TSH and free T4 levels. Obviously, please do understand, like only if the TSH is more than 10, to an extent you can think about hypothyroidism-related obesity. If the TSH is less than 10, obesity is the reason for elevated TSH and not TSH as a cause of obesity. Clear? That's what we refer to as altered thyroid. I've told you multiple times. Then you can do a overnight dexamethasone suppression test or a 24-hour urinary free cortisol to rule out Cushing syndrome. And you can also do a calcium, phosphate and PTH based studies, that is to rule out Albright's hereditary osteodystrophy, which is partly an endocrine cause of obesity as well. Albright's hereditary osteodystrophy. If you want, you can use tests like insulin tolerance test for the purpose of detecting growth hormone deficiency, if you strongly suspect so. Apart from that, this is how you're going to approach childhood obesity. Adult obesity is more easier to understand and identify, so I'm not going to discuss on that. And most of the adulthood related obesities will be either having typical history of some medications or probably having some typical history of other features that are suggestive of endocrine obesity, or probably they'll be having most of the time, 99 to 100% of the times, physiological obesity and lifestyle related problems. That's it. Clear? So we'll be moving on to the assessment now. Assessment of obesity means whether you wanted a lean body mass related issue or whether you want the regional adiposity related measurement. So it has a lot of things to do, but overall the best practically validated method is body mass index, BMI, which is otherwise referred to as a Quetelet index. Even now, BMI is the one that correlates highly with mortality, and it's going to follow a J-shaped curve. So what do you mean by a J-shaped curve? You're going to plot the BMI in x-axis and mortality in y-axis, and the curve is going to be something like this. So this is what we refer to as a J-shaped curve, which means that very low BMI, your mortality is high. At the same time, beyond a point, your mortality is going to increase again. That's why we call it as a J-shaped curve, which means there will be a point where your mortality increases. So there will be a point where your mortality is going to increase, and that is usually at a BMI of more than 30. And that is why this 30 is what we set as a cutoff of obesity. It's not without any evidence. That is the reason why we set a cutoff for obesity. So what is the formula for BMI? Everyone will be knowing that. So it is the weight in kilogram divided by height in meters squared. So the value will be coming as in the index of kilograms per meter square. So this is the value you're going to get. And the BMI, as I told you, it has a very robust correlation with the mortality, and it's one of the simplest indices that we can use in practice, which is having a very good correlation with complications as well. That is why majority of the indications for drugs, your bariatric surgeries, everything will be based on BMI. Even though many people do criticize BMI for its inability to identify this regional adiposity, whether it is abdominal or chest, but whatever, overall, your BMI correlates very well with your overall mortality. So it's a very good index. So let us see what are the classification based on BMI and what will be the class in adults as well as in children. So if the BMI in adults is less than 18.5, or if the BMI in children is less than the 5th percentile, this will be termed as someone who is underweight. And if the BMI in adults is in the range of 18.5 to 24.99, and in child, if it's in the range of 5th to 84th percentile, we'll be calling it as a normal BMI. And if the BMI is in the range of 25 to 29.99 in adults, and if it's in the range of 85th to 94th percentile in children, we'll be calling it as overweight. These are at-risk individuals, and any BMI more than or equal to 30 in adults or BMI more than or equal to 95th percentile in children will be defined as obesity. And this is the practical definition of obesity. And in adults, we have further classifications like a class 1 obesity, which will be defined as BMI in the range of 30 to 34.99. And we have a class 2 obesity, which is defined as BMI in the range of 35 to 39.99. And we have a class 3 obesity, which was previously called as morbid obesity, where the BMI is more than or equal to 40. So class 1 obesity previously called as mild obesity, class 2 obesity previously called as moderate obesity, and class 3 obesity previously called as morbid obesity. And in children, you cannot classify like this, even though there is a definition of morbid obesity in children, which is defined as more than 120% of 95th percentile. More than 120% of 95th percentile is what the definition of morbid obesity in case of children, but only very limited textbook like Indian Academy of Pediatrics textbooks give this. Apart from that, you don't have this definition in many other textbooks. There are some other information with regards to BMI that you have to know. BMI is often criticized to be inadequate for Asians, especially this international classification is not valid for Asians. That's what the questions raised by many Asian forums. So they have given a separate cutoff for Asians. For example, BMI of more than 23 in Asians is supposed to be overweight, and BMI of more than 27 itself in Asians is supposed to be obese. But whether this is valid or not is a different question. We don't have proper study backup or trial data to validate this information, but still many Asian conferences claim this data. In Indians, more than 27 itself, they are taking it to be obese because of the relative excessive fat proportion. That is the reason. Because Indian subcontinent, especially Asians and Chinese, Japanese, tend to have more fat relatively compared to the muscle in comparison to the Caucasian race. That's why you cannot apply the same to Indian. So there is a lot of doubtful things that are going on with respect to the BMI cutoffs for Asians. But anyways, don't need to worry about that. In exams, always go for the international and the WHO cutoff. And there is something called as a lethal BMI concept, which means you have to establish below what BMI it is incompatible with life. That's what we refer to as a lethal BMI. It is defined as if BMI in females are less than 11, or in males if the BMI is less than 13, this is considered to be incompatible with life and they will die for sure, and this is what we refer to as a lethal BMI. And we also have other ways of assessing adiposity. I'm not talking about the overall lean body mass, I'm talking about the adiposity. So there are numerous measurements like neck circumference, waist circumference, but none of them will correlate appropriately with your regional adiposity. And we have skin fold thickness, which is usually measured with a special type of calipers called Herpendon calipers at different areas, which can tell you the regional adiposity. But again, it is not proven to be very accurate or correlating adequately with mortality. And we can use dual energy X-ray absorptiometry, very minimal radiation, 5 to 10 minutes turnover time, but still it is not used very frequently, but it has a good correlation with the regional adiposity. Whether it has a good correlation with mortality or not, we have no idea. We don't have a good study backup. And fourth one, we have bioimpedance testing, which is by far the gold standard for measuring the regional adiposity, but most of the places it is not available, and it is little cumbersome to measure. At the same time, it is costly, and whether this measurements again for regional adiposity, whether it's going to correlate with overall long-term mortality or not, is a big question. So that's why even though these are measures for regional adiposity, but whether they correlate long-term with mortality or not is a big question. That's why we don't use it for a routine practice for determining treatment options. Instead, we stick on to a routine BMI. What are the complications of obesity? We have numerous complications with regards to obesity. We can divide into endocrine complications, and we can divide another one into non-endocrine complications. Endocrine complications include the most and ever important metabolic syndrome. There are many definitions of metabolic syndrome. Majority of the definitions agree with HDL, that is low, agree with triglycerides, that is high, agree with impaired fasting glucose, where the FBG will be high, and they agree with BP, which is high, and hypertension, and they agree with high waist circumference also. The most important difference in the criteria will come from the waist circumference, and they don't really agree with waist circumference that much, especially the numbers that might be different with different population. That's why that is something very controversial. Let us discuss. So metabolic syndrome is based on certain features where you have to have 3 out of 5 features, which I'm going to tell. Number 1 being impaired fasting glucose. If it is more than 100 milligrams per deciliter, I'm going to call it as an impaired fasting glucose. Or if the patient is having a frank type 2 diabetes mellitus, that's also fine. Or if the patient is already on treatment for type 2 diabetes mellitus, I'll be surely taking as one of the components of metabolic syndrome. There's no doubt about that. So this is just a cutoff. But if the patient is already on treatment for diabetes, that's it. That's suggestive of a 1 point in metabolic syndrome. Or if the BP is increased, if it is more than 130/85 millimeters of mercury, or if the patient is already hypertensive, taking some antihypertensive drugs, then that is also another point that is added to the metabolic syndrome diagnostic criteria. And third one, abnormal lipid. So because of obesity, what are the lipids that will be abnormal? As I told you, obesity will increase the triglyceride and lower the HDL, which we have discussed in the previous lipid disorder chapter itself. So I'm going to tell the triglycerides are elevated, that is more than 150 milligrams per deciliter or 150 milligrams percentage. I can tell one of the points for metabolic syndrome. Or if the HDL is low, that is less than 40 in case of males, or if it is less than 50 in case of females. 40 milligrams per deciliter in case of males or 50 milligrams per deciliter in case of females. That is another point for metabolic syndrome. And finally, as I told you, the waist circumference is where many of the guidelines won't agree uniformly. They have different set of guidelines for different population. For example, you have the standard 2001 NCEP ATP 3 guideline, which showed in males, if it is more than or equal to 102 centimeter, and in females, if it is more than 88 centimeter, that is suggestive of metabolic syndrome. And this is what is given in many standard textbooks, more than 88 centimeter in females and more than 102 centimeter in males. But this kind of adiposity distribution is not the case in case of Asian population and other population like Japanese population. So they wanted to give a different cutoff, which came in 2005 in the form of International Diabetes Federation, which modified this waist circumference cutoff to more than 80 centimeter for females and more than 90 centimeter for males. And they also gave a separate cutoff for Japanese. That is, for Japanese males, if it is more than 94 centimeter, that is suggested to be increased waist circumference. For Japanese males alone, they are given a separate cutoff. But overall, for all others, more than 80 centimeter in females and more than 90 centimeter in males is what we consider as a increased waist circumference. And this is specifically titrated to South Asian population. Then in 2005, within a short span of time, the NCEP ATP3 once again modified their guidelines with regards to Asian perspective, not only South Asian perspective, where they told more than 80 centimeter in case of females and more than 90 centimeter in case of males. And finally, JAS classification came in 2009, which agreed to all the other points in metabolic syndrome. Once again, it told increased waist circumference means more than 80 centimeter in females and more than 90 centimeter in males. So I don't know what you will follow in exam, but as per my understanding, I will be following in my clinic this 80 and 90 rule only, especially because this is going to correlate well with Indians and Asian population. But probably for exams, because this is what is given in standard textbooks and many guidelines, so you can use 88 centimeter and 102 centimeter in exams, but you have to understand that it's strictly related to Caucasian cutoffs only. It is for Caucasian race. It's not really applicable for Indian population. So for exams, you can remember, but for practical purposes, remember that 80-90 cutoff for Indians. Clear? Apart from that, you can develop dyslipidemia, which is a endocrine complication. The most important things that are altered in obesity is triglyceride and HDL, where the triglyceride levels will be high and HDL levels will be low. And number 3 is the type 2 diabetes mellitus, which is definitely a complication of obesity, and it's an endocrine complication. What are the non-endocrine complications of obesity? Obviously, hypertension, non-endocrine complication. Remember, for every 1 kilogram loss of weight, you will result in reduction in the systolic blood pressure by 1 millimeters of mercury. And it has a limit, up to 8 to 10 millimeters of mercury you can reduce by this reduction in weight, but not more than that. But still, it is associated with a significant improvement in hypertension as well. So obesity is related to hypertension. Next, atherosclerotic cardiovascular disease. We know that. That is because of dyslipidemia, indirect relationship. And next, we have some pulmonary complications like obstructive sleep apnea and Pickwickian syndrome, that is called obesity hypoventilation syndrome. Both are related to obesity only. And then we have some musculoskeletal complications like gout. One of the important and strongest risk factors for developing high uric acid and gout is obesity. And we also have another musculoskeletal problem in the form of osteoarthritis, especially the knee joint osteoarthritis. Obesity is a very, very important predisposing factor. And we have slipped capital femoral epiphysis in children especially. So that's a complication of obesity, but in children. Then we have some gastrointestinal complications like gallstones, very important, that is due to supersaturation of bile with cholesterol, one of the indirect complications of dyslipidemia due to obesity. And pancreatitis is due to either elevated triglycerides or can be due to gallstones due to obesity itself. And third one, you can develop non-alcoholic fatty liver disease and non-alcoholic steatohepatitis as well, which is also very important hepatic complication of obesity. And obesity is also linked to certain cancers like colon cancer, which is very, very important, especially low fiber diet and diet which is going to constipate your stools and which is associated with high fat, and obesity itself is associated with colon cancer, very, very important. Then female breast cancer, endometrial cancer, esophageal cancer, renal cancer, many of these cancers are related to obesity. And you are going to have a considerable psychiatric complications because of obesity in the form of low self-esteem, depression. So many psychiatric issues are also associated with obesity. So we have discussed on the complications of obesity. Now let us move on to the management, how we are going to treat the obesity. Obesity treatment can be divided into three simple arms. One is going to be the lifestyle modification and psychosocial support, which is very important. Second one, medications, drug therapy. And third, you have surgeries, bariatric surgeries for that. So first, let us see the indications for each and every treatment. So all patients will be receiving lifestyle modifications without a doubt. And medications, please understand it's only adjunct to lifestyle modification, which means it's not a standard therapy for all the patients, which means if the patient is not able to lose weight despite adhering to lifestyle modifications, then only you're going to use the medications. What are the indications? If the BMI is more than 30 or if the BMI is more than 27 with significant obesity-related comorbidities. What are the standard obesity-related comorbidities like type 2 diabetes mellitus, or patient is having dyslipidemia specific to obesity, or the patient is having a systemic hypertension. So these are the obesity-related comorbidities which warrants the treatment, especially if the BMI is more than 27. But always be very sure it's only adjunct to lifestyle management. It's not the management in the first place. You cannot try these medications as a first-line management. Always try lifestyle modification. If the patient is not able to lose weight over a period of time and they find it very difficult, or if they lose weight with lifestyle modification but they are not able to maintain it or sustain it, then you can use medications as an adjunctive therapy but not as a main therapy. And there are a number of bariatric surgeries that are available in the recent era, and the details of which is not important, and we are going to discuss anyways in a short crisp manner in some time. So but let us see the indications of these bariatric surgeries. First indication is a morbidly obese individual, BMI more than 40, or in a class 2 obesity, which is defined as BMI more than or equal to 35, plus significant obesity-related comorbidities like diabetes, hypertension, or dyslipidemia. These are the indications for bariatric surgeries. Currently, we have a number of RCT evidence which clearly tells that bariatric surgeries are very, very effective in patients who are really obese and having diabetes. And there are enough evidences to tell that they can reverse diabetes and they can put the diabetes in remission for a long time. So currently, many centers actually promote this bariatric surgeries as a diabetic surgery rather than a bariatric surgery, but it should not be done, but still they have a really good effect on diabetes. We have now different level of evidences coming from different sources around the world, and they're very good for diabetes. First, let us start with the lifestyle modification, which will be given for almost all individuals. And the target weight loss that you're going to achieve using this lifestyle modification is approximately 5 to 10% in 6 months' time. And this is the most realistic target, and beyond this, It's very difficult to achieve only with lifestyle. It's really impossible. So there are three modalities of lifestyle modification. One is the diet, of course. Second is going to be the physical activity, that is the exercise, of course. And third one is going to be the reduction in the screen time. This is very, very important with regards to children, where you have to be very strict and very sure that the combined screen time of laptops, television, mobile phones should be less than 1 hour per day, not more than that, especially in obese children. And this is supposed to be the very important predictor of future obesity in children. So restrict them to less than 1 hour per day. And diet, very important. And what do you have to do to reduce your weight? Nothing, just reduce your calories. So all you need is calorie restriction, that's it. And very surprisingly, your macronutrient composition will not determine how much weight you're going to lose. Whatever may be the macronutrient composition, if you reduce the calories you're going to take, you're going to result in loss of weight, which means you can take 80% of carbohydrates and 20% of fat, or you can take 20% of carbohydrates and 80% of fat, doesn't matter. If you take less calories, you're going to result in loss of weight. The macronutrient composition is not going to predict your weight loss. It's only the calorie restriction that's going to result in significant loss of weight. So what is the calories you can recommend? For that matters, for a female, I can recommend approximately 1200 to 1500 kilocalories per day. This is for adults, not for children. And for males, I can recommend approximately 1500 to 1800 kilocalories per day. This is what I tell to my dietitian as well to recommend to the patients. Or overall, you can suggest a 70 kilocalories per day of energy deficit. If you don't know how much to give because their weight is huge, then you can suggest overall an approximate 750 kilocalories per day of energy deficit. That will reduce the weight to a substantial amount, at least 5 to 10% you will achieve. With regards to exercise, minimum 45 minutes per day of moderate intensity exercise, if not vigorous intensity, at least moderate intensity is what is preferred, and minimum cumulative exercise should be at least more than 150 minutes per week, and you can slowly increase to more than 300 minutes per week, but minimum you should maintain a standard of at least more than 150 minutes per week of moderate intensity exercise, or more than 45 minutes per day, whichever is good. And even if you do more than 300 minutes per week, it's okay for me. Even if you do more than 500 minutes per week, it's okay for me. The more you do, the better benefit you're going to get in the form of reduction in the hypertension, reduction in the atherosclerotic cardiovascular risk, improvement in the lipid profile, as well as reduction in the body weight. But you have to understand that exercise alone have a very modest effect on weight loss. Only mild effect on weight loss will be there. You don't get a substantial amount of loss of weight. If you're taking high amount of calories and doing exercise and you're burning, that doesn't matter. But if you are going to perform exercise and dietary measures in the same sitting, you are going to have augmented weight loss. You can produce a good amount of weight loss, at least to the 5 to 10% range. Beyond 10%, it's very difficult. With diet and exercise alone, you need to have other help from pharmacological and surgical management therapies. Then we are moving on to the pharmacological therapy. There are some FDA recommended drugs like phentermine and topiramate combination, liraglutide, then orlistat, then we have naltrexone bupropion combination. So we have a lot of drugs that can be used, but we all know what are going to be the indications of drugs. As I told you, BMI more than 30, or if the BMI is more than 27 with significant obesity-related comorbidities. And you have to use these drugs as only as an adjunct. As I told you before multiple times, it's not a first-line therapy. It's only an adjunct to the lifestyle management. If you cannot lose weight with drugs, then it's fine. You can start with pharmacological therapy. Or if you are losing weight with lifestyle management, but you are not able to sustain. And this is one of the very important points that you have to know, that lifestyle modification is not something that can be sustained for a longer period of time. Even though people do with a lot of excitement and a lot of commitment in the beginning, but over time their commitment will fade off and they cannot be able to sustain this lifestyle modification for a long time. So in those individuals also, pharmacological treatment may be beneficial. So how long you can give pharmacological treatment? How long ever you want, that is the idea. But you should stop this pharmacological therapy if you do not have significant amount of weight loss. If less than 5% of the weight loss in 3 months, this is a very, very important indication to stop. You have to stop the drug, which means without reaching any significant beneficial point, it's not good to continue this pharmacological therapies, which are going to also have significant amount of side effects in terms of patient tolerability and other problems like hypertension. You will be resulting in certain drugs like phentermine. So it's better not to continue if you do not have any substantial benefit. So cutoff is, if you do not lose at least 5% of weight in 3 months, it's better to stop these drugs. Suppose if you achieve a significant amount of weight loss like 6% or 10% weight loss in 3 months, then it's better to continue these drugs as long as the patient is okay, as long as they tolerate the drug, as long as they do not develop the significant side effects, it's okay. So there is no definitive cutoff for how long you have to continue, but there is a cutoff for when to stop the pharmacological therapy. That is, if you do not lose at least 5% of body weight in 3 months, you can stop the pharmacological therapy. So many drugs are there, and these drugs are going to act by different mechanisms, and that's why the pathophysiology comes into play. The same diagram I have given, but I have filled all these things and I kept for you so that it will be easier for me to tell you where these drugs are acting. Let's start with one of the very commonly prescribed drugs, that is orlistat, which is a gastric and intestinal lipase inhibitor. So that's why it's called orlistat. Lipase inhibitor is why we refer to as orlistat. And obviously the side effects can be well understood because they are going to produce fat malabsorption, and there could be deficiency of vitamins A, D, E and K, which are fat soluble vitamins, and they can produce steatorrhea and some GI side effects. Overall, it's a well tolerated drug, but produce only modest amount of weight loss, practically around only 3%, which usually is not enough to continue this drug for a long time. So it can produce short-term weight loss, but you can maintain weight loss only with orlistat. Then you have few other drugs. One of the most upcoming drugs is going to be liraglutide, which is a GLP-1 receptor agonist. So we know GLP-1 receptor agonists like liraglutide can work on the POMC CART pathway, and they can produce anorexia, increase satiety, reduced appetite, and hence weight loss. They can also work on the stomach and reduce the gastric motility, thereby augmenting the satiety effect produced by the central mechanism. And similarly, they can also work on the nucleus accumbens. I told you liraglutide stimulation or GLP-1 receptor stimulation in the nucleus accumbens neurons is going to reduce the reward and reduce the liking and the wanting for the food. Similarly, you have mu-opioid receptor antagonist in the form of naltrexone. As I told you, stimulation of the mu-opioid receptors will result in increased reward and liking and wanting for the food. So blocking the mu-opioid receptor in the nucleus accumbens can result in reduced reward and liking and wanting for the food. Similarly, mu-opioid receptors are also present in the anorexogenic pathway, POMC CART mechanism, where they are going to produce auto-inhibition on the POMC CART pathway. So when you are using a naltrexone, you are going to block the auto-inhibition done by the mu receptors, which means there will be more stimulation of the anorexogenic pathway, resulting in weight loss. You have some experimental drugs like MC4 receptor stimulators like seth melnotide, which is highly experimental. And we have leptin analogs like metraleptin. Obviously, we know the effects of leptin to reduce the weight, but the usefulness in adults is highly questionable. But in children who's having leptin deficiency and related hyperphagia, and in certain congenital lipodystrophy conditions, leptin is useful, but it's still an experimental drug only. But there are many other drugs which act on multiple areas. For example, the GABAergic projection and GABAergic firing can be stimulated by a drug called topiramate, and this is supposed to be one of the major effects of topiramate on weight. That's how they produce weight loss, and they reduce the appetite by suppressing the orexogenic pathway through excessive GABAergic firing on the orexogenic pathway. And noradrenaline pathway can be stimulated obviously by phentermine. Phentermine is a catecholamine. Phentermine is an amphetamine analog, which means it's something structurally related to amphetamine. It's going to work on the TAR1 receptor. This is a trace amine related receptor, a regulated receptor. That's a TAR1 receptor agonist. So once you stimulate the TAR1 receptor using phentermine, you are going to increase the noradrenaline levels in the brain and thereby increasing the firing of the noradrenergic neurons. So clear, it's a TAR1 receptor stimulator. So once noradrenaline levels rise, they are going to stimulate the anorexogenic pathway and they're going to produce weight loss. Similarly, serotonin pathways can be stimulated. One of the main drugs that stimulate the serotonin pathway is zonisamide. It's not an approved agent for weight loss, but still zonisamide can stimulate the serotonergic pathway and thereby once again stimulating the anorexogenic mechanism, POMC CART mechanism, and they can produce weight loss. And a drug that was banned but was once used as a weight losing agent which stimulates the 5-HT2C receptor in the central nervous system is lorcaserin, which can stimulate the 5-HT2C receptor and thereby stimulating the serotonergic pathway and thereby stimulating the anorexogenic pathway, POMC CART mechanism, thereby producing weight loss, by producing more satiety. And this was banned currently. You don't use it right now because of this tumorogenic effect. Trial results showed that it produces increased risk of developing certain tumors. And there are drugs that can augment the dopaminergic pathways in the prefrontal cortex. And two drugs that are thought to produce this kind of effect is phentermine and zonisamide. Phentermine and zonisamide are thought to augment the dopamine release in the prefrontal cortex and dopaminergic pathways within the prefrontal cortex so that you establish more control over the food. So your control over the food will increase, which means your inhibitory behavior on the food will increase. That's what we define as control. So that's how phentermine and zonisamide may work. And we have a final drug in the form of bupropion. How bupropion works? Bupropion is basically an antidepressant agent, but the mechanism of action is thought to be due to NDRI, that is noradrenaline dopamine reuptake inhibitor. So which means they are going to increase the levels of noradrenaline and dopamine. So increasing levels of noradrenaline within the hypothalamus is thought to be the effect on anorexia. That's how they promote anorexia and stimulate the anorexogenic pathway. And once again, when they increase the dopamine levels within the prefrontal cortex, you can establish more control. And at the same time, bupropion experimentally can augment the naltrexone effect on the hypothalamus. At the same time, it is thought to increase the MSH production by itself, thereby your action on the MC4 receptors will be more, so that bupropion works by multiple mechanisms. So that is the reason most of the time bupropion is given along with naltrexone, because it augments the naltrexone effect on the anorexogenic pathway. So we have multiple drugs working by different mechanisms, but we are going to talk about the FDA approved drugs for weight loss. Only the FDA approved drugs. Remember, two drugs are completely banned. One is your lorcaserin and second is rimonabant, which worked on the cannabinoid receptors by blocking them, and that caused serious psychiatric effects. So rimonabant, lorcaserin is not in the market right now. So let us put a small table on certain drugs that are approved by FDA and what will be the proportion of weight loss they will be producing, and what will be the mechanism of action of these drugs, and what will be the side effects of these drugs, and what will be the dosage of these drugs, and finally let us finish off with certain comments. First drug is going to be the phentermine, one of the very commonly prescribed drug in Western countries. Even though in India it's not commonly prescribed, orlistat is the commonly prescribed one in India. Weight loss that is promoted by phentermine is a neat 5%, which is okay to continue the drug. Mechanism of action is going to be adrenergic and in the CNS, we know that. And the side effects, obviously the adrenergic side effects like hypertension, increased heart rate are going to be the side effects. And dosage, 15 to 37.5 milligram once a day, usually in the morning. And comments, it's one of the most cheapest drugs available in the market right now, even though in India a lot of scheduling is there, but it's the cheapest overall. And at the same time, you have to be cautious if you are using in patients with coronary artery disease and cerebrovascular accident. Be very careful because they can produce some adverse effects in these conditions. Number two, we have a combination of phentermine and topiramate, and trust me, this is supposed to be the most effective therapy for weight loss. Amount of weight loss they're going to produce approximately 10%, which is almost 8 kg in 3 months, which is the maximum by any drug, any pharmacological drug. You cannot achieve more than this by a pharmacological therapy. This is the maximum weight loss that you can produce. And mechanism adrenergic by phentermine and CNS by phentermine and topiramate both. And side effects, you're going to have phentermine effects like increased BP and increased heart rate. At the same time, you'll have topiramate effects like cognitive effects, sedating effects. It's a very, very sedating agent, topiramate, and they are teratogenic as well. You have to be very, very careful about that, especially when you're giving for young girls. Dosage, you have to titrate sequentially. Initially, you start with 3.75 bar 23 milligram dose. That's the basic dose. You try for 14 days. Then you can up titrate to 7.5 bar 46 milligram dose, which you can give for 14 days. And if you don't see any beneficial effect with 7.5 bar 46 milligram, you can stop with that. If you are seeing some amount of weight loss, then you can increase the dose to 11.25 bar 69 milligram. You can give for another 14 days, and finally you can up titrate to the maximum dose of 15 bar 92 milligram, which is going to be the maximum dose of phentermine topiramate combination. And obviously this drug is absolutely contraindicated in patients with coronary artery disease and cerebrovascular accident, especially in last 6 months. You have to be very cautious in this regards. And third drug we're going to discuss is on lorcaserin. Even though it was banned right now, let us discuss. Please understand it's banned, and the amount of weight loss produced is 3.5%, which is extremely modest. And the mechanism of action is, it is a 5-HT2C stimulant, and one of the most important side effects is headache. And the dose is 10 milligram 2 times a day. One of the favorite drugs by many practitioners, especially psychiatric consultants. And avoid with SSRI, because this is a serotonergic drug, and with SSRIs they can produce serotonin syndrome also. And currently why it was banned? Because it produces increased risk of certain cancer like lung, pancreas and colon. That's why it was banned. And it was clearly proved by 2 meta-analysis, and it was submitted to FDA, and that's why this drug was banned. Number 4, we have a naltrexone will not be given alone, so it will be given along with bupropion. Naltrexone bupropion combination, where they're going to produce a weight loss of approximately 4%, again very modest, and their effects we know only on the CNS. I've already showed you the entire mechanism of action, and side effects is going to be nausea, headache and constipation, opioid side effect, constipation. And dose is usually 8 bar 90 milligram, and you can give 2 tablets 2 times a day. This is the standard dose. Even though single release tablets are available, but we don't prefer that because of some other pharmacokinetic advantages with this. And there's nothing to comment on this. And we have another FDA approved drug for weight loss, that is liraglutide, which produces approximately 8% of weight loss. Remember, this is the best single drug that produces maximum weight loss. Remember, combination is different. Phentermine topiramate produces the maximum weight loss among all the pharmacological drugs, but liraglutide is the drug which is a single drug to produce maximum weight loss, 8%, approximately 6 to 8 kilogram weight loss, and it's going to act on the multiple locations. It's going to work like a GLP-1 receptor agonist, not only in the CNS but in the stomach as well. And most importantly, they can produce nausea and vomiting and diarrhea. GI side effects are very, very common because they produce gastroparesis, reduce gastric motility. And the dosage is 3 milligram subcutaneous OD. Saxenda, very, very commonly used drug. 3 milligram subcutaneous OD. And this is one of the best drugs. Suppose if the patient is a pre-diabetic or a diabetic. If the patient is a pre-diabetic, but not a frank diabetes mellitus, the use of liraglutide for obesity can actually postpone the development of diabetes by a considerable duration. That's why this drug is one of the very good drugs for patients with pre-diabetes and those who are morbidly obese and they're having diabetes. And finally, commonly used drug in India but not going to produce a substantial amount of weight loss is orlistat, produce only a very modest 3% of weight loss. It is a gastric and intestinal lipase inhibitor. Side effects are going to be diarrhea and gastrointestinal side effects, especially steatorrhea and malabsorption of fat-soluble vitamins. Dosage is approximately 60 to 120 milligram. You can give BD or even a TDS dose, but you will be giving along with meal. And it's usually a well-tolerated drug. And commons, as I told you, fat-soluble vitamin deficiency is something you have to think about. So I have told you the summaries of all these drugs along with the doses, which is going to be very important for your exams. And let me tell you the cautions with these drugs and what are the contraindications to these drugs. There are some drugs in the list which I've told which are going to increase the seizure potential by lowering the seizure threshold. One is obviously bupropion. Bupropion is a very, very important drug that can lower the seizure threshold and produce seizures, which we have discussed already in the anti-smoking drugs itself. That time itself I have discussed about this. Obviously, you are not going to use this alone. You are going to use this with naltrexone combination. And similarly, there are some risk of kidney stones with topiramate. Obviously, topiramate you are not going to use alone. According to FDA recommendation, you are going to use with phentermine. So the topiramate component of topiramate phentermine combination is going to produce kidney stones, and kidney stones can be due to orlistat, and that's due to fat malabsorption. And glaucoma. Glaucoma can be as a result of topiramate and phentermine combination, and here it is due to phentermine component, not topiramate. Glaucoma is due to phentermine component. Hypertension is associated with naltrexone and bupropion combination, and it can be related to phentermine or phentermine topiramate combination as well. Can produce hypertension, but very importantly with phentermine combination. And coronary artery disease and CVA, you have to be very careful when you are using this phentermine topiramate combination. Phentermine alone is okay, not bad, but phentermine topiramate is very bad. So what you will do in renal failure? In renal failure, you have to definitely avoid any GLP-1 analog, especially liraglutide should be avoided if eGFR is less than 30. So two L's I'm going to avoid in renal failure, liraglutide and lorcaserin. But anyway, lorcaserin is banned, so not a problem. We are not going to use liraglutide. And you have to give half dose of the other two drugs, the phentermine topiramate combination and naltrexone bupropion combination you can use at a half dose. And what about hepatic failure? With hepatic failure, once again, I'm going to avoid definitely liraglutide. There's no doubt about that. Liraglutide and lorcaserin. Anyway, lorcaserin is banned, so not a problem now. So liraglutide has to be avoided in patients with hepatic failure. And you have to give half dose of phentermine topiramate combination, and you have to give only quarter dose with regards to naltrexone bupropion combination. And if the patient is already using SSRIs, do not give lorcaserin because of the risk of serotonin syndrome. Again, it's not a problem right now because it is banned already by FDA. FDA has withdrawn its recommendation as an anti-obesity drug by February 2020. So you are not going to use this anymore, this drug. This is a figure that will tell you a very good idea on how much weight loss is produced by these drugs. You can see the most effective is going to be phentermine topiramate combination and liraglutide, which is going to produce maximum amount of weight loss by approximately 8.8 kilogram in 3 months with regards to phentermine topiramate, and 5.6 kilogram with respect to liraglutide. The best effective single drug is liraglutide, and the overall best drug for producing weight loss is phentermine topiramate combination. But the cheapest drug is phentermine alone. Phentermine is the cheapest one, but even though it produces a modest amount of weight loss, you can see among all the approved drugs, orlistat is the one that produces least amount of weight loss. It's not a very good drug, it produces only very modest weight loss, but still very commonly used in India. And there are some off-label drugs that we use, like topiramate alone, bupropion alone, exenatide, which is another GLP-1 analog that does not produce that much weight loss, zonisamide, metformin alone. So these are some other drugs that we use as an off-label therapy for promoting weight loss. Remember, metformin is a commonly prescribed weight-losing drug, but don't give metformin unless and until patient is having some other issues like diabetes mellitus or a pre-diabetes. But remember, metformin promotes weight loss by a completely different mechanism through something called AMP kinase activity increase. So they're going to increase the AMP kinase activity, and that's how they're going to promote this weight loss in the brain, because increasing the AMP kinase activity will increase the energy expenditure, and they will promote lipolysis, and they will mobilize the fat, and at the same time they will increase the satiety in the brain. Apart from that, this has multiple effects of improving the insulin sensitivity as well. So details of how metformin works, let us discuss after some time in the diabetes chapter. But they promote the AMP kinase activity indirectly. This is not a direct stimulator of AMP kinase activity, it's an indirect stimulator of AMP kinase activity, and that's how they're going to promote weight loss. It's a completely different mechanism. It's not related to the usual mechanisms which we have seen till now. So overall, this graph is very important. It will give you a good idea what are the drugs that are used as FDA recommended, and what are the drugs we are using off-label, which is not yet recommended by FDA. Then finally, we are moving on to the bariatric surgeries with regards to weight loss and obesity. Bariatric surgeries indications, as I told you before, BMI more than 40, morbidly obese, or if the patient is having BMI more than 35, that is class 2 obesity with significant obesity-related comorbids, especially diabetes mellitus. That's going to respond dramatically to your bariatric surgery, according to many randomized controlled trials. And basically, bariatric surgeries can be divided into three. First category comes under restrictive surgeries, second category comes under malabsorptive surgeries, and the third category is the combination of restrictive and malabsorptive procedures. So brief introduction of all these procedures. First one is the very commonly performed LAGB surgery, that is laparoscopic adjusted gastric banding, where we'll be applying a band-like device which is going to constrict at the proximal portion of the stomach. You will be creating only a very small pouch like what is shown here, and you can take only this much amount of food that is going to be held by the pouch, and after that you will not be able to take the food, which means it's a purely restrictive procedure. And you will be having a port that is attached to this band, and it will be placed in the subcutaneous tissue, and by infusing fluid into that, you can determine, and the patient itself can determine how much food he wants to take by inflating that much amount of the band that is inside. And next one is the vertical sleeve gastrectomy, so where major part of the stomach will be resected. It's a simple procedure, and you're going to especially remove this part of the stomach along the greater curvature, and majority of the body of the stomach will be removed, and you're going to keep only the lesser curvature in the pylorus, and you will result in formation of a tubular kind of a stomach. So that's going to restrict your food intake again. Again, it's a purely restrictive procedure. And third one, you have a vertically banded gastroplasty or vertical band gastroplasty. Here it's again a restrictive procedure where you're going to create a vertical staple like this, and you're going to isolate majority of the stomach, and you're going to produce restriction by creating a band and creating a small proximal pouch, and the stomach can only receive so much amount of food. And once again, it's a purely restrictive procedure. And the fourth one is intragastric balloon, which is not really performed that much nowadays because of high rates of failure, where there will be a balloon that will be placed inside the stomach that is going to restrict the amount of food intake. And usually with pure restrictive procedures, you are going to face high rates of failure, and you cannot sustain weight loss for a longer period of time. So that is a problem with this pure restrictive procedures. Vertical sleeve gastrectomy to an extent is beneficial compared to the other procedures, but overall restrictive procedures cannot sustain weight loss for a longer period of time, with special regards to your laparoscopic adjusted gastric banding, vertical band gastroplasty, and your gastric balloon has the highest failure rates of all. And malabsorptive procedures, they are going to isolate a particular portion of the intestine from performing the function of absorption. So that's how they promote weight loss. The first one is the jejunolial bypass. So in this, you are going to transect the jejunum at the level just distal to the ligament of Treats, and you're going to take the proximal segment, and you're going to anastomose that in the ileum just proximal to the ileocecal junction, which means the food now that you eat is going to just pass through the duodenum and they will directly enter the ileum and distal part of the ileum, and they're going to enter the colon, which means you are isolating a major portion of the jejunum and the ileum, which means the absorption will be very, very poor, resulting in weight loss. This is a purely malabsorptive procedure. There is no restriction involved in this. And the second procedure is biliopancreatic diversion with duodenal switch operation. Very complicated. At the same time, there is a high risk of needing revision surgeries for this, and it's not a very good surgery as of now, not recommended by many, but still. In this, you're going to first induce a restriction. It's like a combination, but still it's more of a malabsorptive. It's a predominantly malabsorptive surgery. That's why we are putting under this heading. So we're going to create a small restriction by resecting major portion of the stomach, and you'll be resecting the duodenum also just distal to the pylorus. So you'll be creating a stomach pouch with small portion of the stomach and pylorus left. And this duodenum that is resected along with the jejunum will be isolated, and the ileum also will be resected. At the distal part of the jejunum, you will be resecting the ileum also. Usually the point at which the ileum is resected will be approximately 50 to 100 centimeter proximal to the ileocecal junction. So you will be resecting the ileum also, and the resected ileal segment will be anastomosed to the stomach pouch with the help of side anastomosis. And this limb, this is what we refer to as a biliopancreatic limb. This is nothing but an isolated duodenum and the jejunum that will be anastomosed to the ileum just proximal to the ileocecal junction. So you are going to create a biliopancreatic limb, and that is the isolated segment of the intestine, and that's going to be not absorbing any nutrients, and that's how you promote a weight loss. And this is the Roux-en-Y gastric bypass, and this is one of the very commonly performed surgeries and very effective. So where initially you will be creating a good amount of restriction by creating a small pouch by transecting a majority of the stomach away. So you're going to staple it and you're going to produce a small pouch, which means your stomach can receive only so much amount of food. And after that, you're going to make a second resection at the jejunum, just distal to the ligament of Treats, and the distal portion you're going to take it up and you're going to anastomose at the pouch that you have created, and the proximal portion of the transected jejunum is going to be anastomosed again towards the jejunum with end-to side anastomosis. That's what you're going to do, which means the food that you're going to eat is going to be very less, and whatever food that you're eating less is going to come through this row limb. So this is what we refer to as a row limb, and it's going to come through the row limb and they're going to enter the distal part of the jejunum directly. So which means you are isolating this part of the stomach along with the duodenum, along with some portion of the jejunum as well. So this is what we refer to as a Roux-en-Y anastomosis. So this is a combined restrictive as well as malabsorptive procedure. The more details obviously we will be studying in surgery, but at least the figures and the nomenclature you have to know, which is restrictive, which is malabsorptive, which is a combination of restrictive and malabsorptive surgery. But the three most commonly performed surgeries in the world are laparoscopic adjusted gastric banding. This is what the patient prefers most of the time. And second one is vertical sleeve gastrectomy. And the third one is the Roux-en-Y gastric bypass. So RYGB. So these are three commonly performed surgeries. And among this, the most effective is going to be the Roux-en-Y gastric bypass only, but it's still associated with a little bit of more complications compared to other procedures. Laparoscopic gastric banding, let us compare each and everything. The amount of weight loss that is produced is approximately 40 to 45% of excess body weight. Here EBW stands for excess body weight. 40 to 45% of the excess body weight we are comparing at 2 years. And vertical sleeve gastrectomy is going to produce 50 to 60% of the weight loss of excess body weight. And Roux-en-Y gastric bypass is going to produce approximately 60 to 70% of weight loss from the excess body weight. So this is going to be the most effective procedure by default. And what is going to be the length of surgery or duration of surgery? The length of surgery for LAGB is approximately 1 hour, vertical sleeve gastrectomy is approximately 1 hour, and Roux-en-Y gastric bypass takes a little bit of more time, and you need a more longer general anesthesia for approximately 2 hours. And again, this length of surgery is completely dependent on the surgical expertise. I'm not anyone to comment on that. So it depends on the surgeon. Fine. And again, duration of hospital stay. Once again, depends on the patient's comorbid status. Usually for LAGB, it's only 1 day. For vertical sleeve gastrectomy is 1 day. And RVGB usually needs 2 days. Unless and until there are no other complications which warrants extra stay in the hospital. And mortality rates with LAGB is less than 0.05%, which means it is the most safest procedure by default. That's why majority of the patients prefer this LAGB, and it's very reversible procedure. That's why mortality rates is 1.1 to 0.3% with regards to your vertical sleeve gastrectomy, and for Roe and Y gastric bypass, it's going to be somewhere around 0.3 to 0.5%, which means it's going to have a relatively higher risk of death compared to other procedures. That is the reason why patients prefer this LAGB. And whether you can reverse or not, yes, absolutely, LAGB is completely reversible, almost completely. And vertical sleeve gastrectomy is not, because you have transected and removed the stomach, and Roe and Y gastric bypass is very difficult to reverse again. So it's not that easy to reverse. You can do it under surgical expertise, but very difficult to reverse. That's the reason, once again, why LAGB is the preferred surgery by the patients. And you'll be facing some other issues with these surgeries in the form of inadequate weight loss, that is specially related to laparoscopic adjusted gastric banding procedure. And it will be ill sustained. It will not be sustained for a longer period of time. It is very difficult to sustain weight loss with this kind of gastric banding related surgeries. And patient will be requesting for band removal over a period of time, and that's once again another complication with this surgery, because it can be reversed. At the same time, patient cannot tolerate the hunger. That is because the fundus is the one that secretes maximum ghrelin, and the food that is going through the normal route, normal anatomical route, is going to stimulate the fundus, and they suppress the ghrelin. And after some time, once again, they're going to produce more ghrelin if the food has passed and the stomach is empty. And this excessive ghrelin will create a intolerable hunger. So which means initially they will have a good satiety, but within a short span of time, they'll get hungry again. So they cannot tolerate this. So they will ask for band removal over a period of time. So that's one main problem with LAGB. But that's a very, very good advantage in case of this isolation procedures, especially procedures like Roe and Y gastric bypass that suppress ghrelin to maximum amount. In fact, untreated levels of ghrelin. The reason is because the food does not go through the stomach and fundus at all. It's going through the row limb, through a small pouch that is created proximally. So which means this fundus and majority of the stomach are chronically empty. Chronically empty. So you can ask me the question that if the ghrelin is released when the stomach is empty, when the patient is not taking food, chronically empty stomach should produce chronically elevated ghrelin, isn't it? So that's where your basic physiology comes into place. So chronically empty means you'll have a chronic stimulation of ghrelin producing cells in the fundus. So chronic stimulation will result in tachyphylaxis and down regulation of this receptors and organs, resulting in reduced ghrelin. You can imagine that continuous stimulation of receptor will result in down regulation and tachyphylaxis, and that's how you result in reduced ghrelin. And that's how Roe and Y is associated with significant reduction in the ghrelin levels and much improved satiety and reduced appetite. So they don't have that much amount of appetite. That's why it's associated with maximum amount of weight loss as well. And there's not much issues with vertical sleeve gastrectomy except for the micronutrient deficiencies. And Roe and Y can produce dumping syndrome as well. Roe and Y can produce the dumping syndrome as well. Dumping syndrome is very commonly studied very nicely in your undergraduate surgery textbooks itself after Billroth surgeries, but it can happen after Roe and Y surgeries. After surgery, you need lifelong micronutrient replacement. That's very important to understand. You cannot leave the patients just like that. So micronutrient supply is lifelong, essentially, for these patients, especially if you're doing a malabsorptive process, because you've isolated a particular segment of stomach and intestine that is going to absorb some essential nutrients in the form of, for example, you have to give iron, which is optional, especially if you're isolating stomach and duodenum, then definitely you have to do that. So iron in the form of approximately 45 to 60 milligrams per day. And number 2, multivitamin complex, which contains iron, folic acid, and thiamine, and calcium, especially if duodenum is isolated, at 1200 to 1500 milligrams per day. And number 4, vitamin B12 at 500 to 1000 micrograms per day. And you can also give vitamin D supplementation at 3000 international units per day. And this micronutrient replacement is essentially lifelong, and it increases the cost of care from the patient side. And you have to screen for deficiencies, which means the patient will go for deficiencies of all these micronutrients. So you have to screen for this at 3 months, 6 months, 12 months. And after this, you have to screen annually. Plus, you have to avoid pregnancies. If it is a female, they have to avoid pregnancy for at least 12 to 24 months to ensure surgical integrity. And patient has to avoid NSAIDs, any form of tobacco, and probably alcohol. Alcohol is an optional thing, but probably alcohol has to be avoided. So these are the additional care that you have to take after the bariatric surgery. So we have discussed in detail about the obesity and its related complications and their management. And final summary of what I want to tell is obesity is something preventable, and don't go into all this extent. So have a good lifestyle and prevent obesity, which is very much preventable. Have a healthy and a non-sedentary and an active lifestyle, and do exercise regularly, and have a good and a proper diet. And we all are going to fight obesity pandemic in a very good way. And as a doctor, we have to be very responsible in terms of obesity and advise the patients very vigorously and very logically. And if you spend extra 5 to 10 minutes of the patients in addressing their lifestyle, they'll definitely take it. And with this, I hope we'll fight obesity, and we'll go to the next chapter on diabetes mellitus.